The broadcast is now starting. All attendees are in listen-only mode.
Hello, thank you for joining us for HSG's educational session on patient attraction and retention access. This focuses on the role of patient access to being able to adequately and favorably attract and retain patients within your employee network or within your hospital system. I am Terry McWilliams, Director and Chief Clinical Consultant here at HSG. We're including my contact information so you can submit questions directly to me after reviewing the educational session. Again, we welcome direct contact and any questions you may have based on the materials that are presented. So with that brief introduction, let's go ahead and get started with the session. Today we'll talk a little bit about the introduction, why patient access is important to network operations and sustainability, how patient access can be measured so that you can determine whether you feel access is, quote, adequate or not, and then the multiple factors affecting access. So if you want to really work on your patient access as a whole, what factors might be underlying or the ability to attract and retain patients based on having favorable access. And then finally, just a word of advice regarding the approach with providers and staff, very briefly. So, quite frankly, having adequate patient access to care is a linchpin for health system sustainability because it does affect the ability to attract and retain patients within the employed network and within the health system structure. We can no longer take a passive role with patient access. I mean, it used to be, if you go back 30 years ago, Dr. Smith is so great that, it takes 6 months to get into him, to see him. Isn't that, he's worth the wait. Or alternatively, he must be good because it takes 3 months to get an appointment. This no longer flies. Patients today do not accept that. Without acceptable access, patients will seek care elsewhere. The loyalty to individual providers or to health systems and employed networks is diminishing with the younger generations, but even with the more established older generations. Patients will seek care elsewhere if timely, convenient access to care is not available in their primary preferred provider network. All referral management efforts get nullified because regardless of tracking referrals and trying to ensure that patients remain within the system, if patients cannot access care within the system, then the best referral management system is null and void. And finally, as alluded to above, rather than being a badge of practice reputation to have very delayed access to care, today, practice and provider reputation is tarnished if there's not convenient access to care. So we've talked a lot so far about patient access to care, but we should define what we mean by that. And the most customer-centric definition is the ability to accommodate requests for patient care that is consistent with the patient and provider expectations or desires. So that's kind of a whole lot of variables within that short phrase. Access simply is measuring the ability to accommodate requests for care, but the customer-centric piece of it is consistent with patient and provider expectations or desires, not necessarily the one who is rendering care today, although that does factor into it, but the other providers within the patient care sphere. So let's explore that last area a little bit more so that we're all clear on where all these expectations and desires are originating. So the patients are the easiest, but this may be existing patients or those desiring a new relationship with a provider, whether it's primary care or other specialty care. Patients with an existing relationship want to get in to see their provider when they feel they need to, or to at least communicate with their provider when they feel they need to. This could be for a follow-up of a chronic condition. This could be for same-day access, or this could be for preventive care services. The new relationship is just that, establishing a new relationship, getting in with a provider, whether it's a primary care provider or another specialty care provider, and establishing a relationship, whether by direct referral, by informal referral, or being new to an area. Patients who cannot have access will look elsewhere. Treating providers, and this concept primarily relates to follow-up of recent or past interactions with the patient. So if a provider says, I'd like you to come back in 5 days to see me for this condition, and the patient goes to check out and they say, well, the earliest we can get you in is next month, that doesn't really meet the treating provider's expectation about getting in to see him or her again. This also can relate to new patient referrals once the referral is reviewed. So for instance, a consultant, specialty physician, reviews a referral consult and says, boy, we really need to see this person in the next 3 days. And the desk says, I'm sorry, there isn't any spot available in the next 3 days. Without treating provider intervention, the system needs to be able to accommodate these kinds of requests to meet treating provider expectations and desires. Referring providers also have expectations, but these expectations actually go in both directions. Referring provider to consulting provider, I would like this patient to be seen, and I'm sorry, 6 months is not an adequate time frame. But also consulting provider back to referring provider. During today's visit, I noticed the patient's blood pressure to be elevated beyond reasonable parameters. And I think the patient needs to see you again in the next week, and being told by the person scheduling the patient or consulting provider's office, I'm sorry, we don't have an appointment for the next 3 weeks. So it goes across the board and in both directions in that referring and consulting provider mix. And then a final area to touch on this at this time is from a treating institution for transitional care management, whether that's an inpatient stay, a subacute care stay, an emergency department interaction, or urgent care center interaction with required follow-up, and then other outside provider arrangements. And again, we already talked about from a treating provider back into the system and managing transitions of care throughout the continuum. This is a very large area, and meeting transitional care management parameters within, quote, reasonable timeframes have a significant impact on patient care and patient well-being. So we think that these are the underpinnings of where these expectations and desires are coming from. So how do we know if we have adequate patient access to care? And the old axiom, you don't know if you don't measure it, comes into being. And so there are a number of recommended metrics that could apply to at least get an idea if you have acceptable access. Keeping in mind that regardless of what we measure, for any individual patient circumstance at any given time, it's meeting that expectation on the part of either the patient or the provider that's looking for the care delivery. So probably the most patient-centric measure for patient access comes with the CG-CAPS survey questions. There are 2 that specifically deal with access to care. And the first is, in the last 6 months, when you contacted this provider's office to get an appointment for care you needed right away, that's their emphasis. How often did you get an appointment as soon as you needed? That's our emphasis. And the responses are never, sometimes, usually, or always. Similarly, for follow-up or routine care, in the last 6 months, when you made an appointment for checkup or routine care with this provider, how often did you get an appointment as soon as you needed? Again, our emphasis in the italicized underlined area. And the responses are the same, never, sometimes, usually, or always. This really, it comes down to a very patient-centric approach, doesn't it? So, you as a patient, as soon as you needed care, were you able to get the care that you needed? Clearly, this is only applicable to established patients, meaning patients that were seen in the office, as opposed to patients that were seeking care but unable to gain access to the office. But this patient population, however, should be the one that's the most readily retainable. They've already been attracted to the practice. They want to maintain a relationship with the practice. And so these are the ones that you can't afford not to accommodate. Other metrics include time to the third next available appointment by appointment type, by provider, and by practice. This has become a well-recognized, recommended metric as it's objective, readily available, and benchmarkable. MGMA has benchmarks by specialty, for example. If we only go to the time to the next available appointment by type, provider, or practice, that can be impacted by late cancellations or other special cause variations, and really does not represent what is reliably present and access that's reliably present in the office or the system. Some EMRs can report this directly, but many EMR platforms do not, and so this can require periodic manual determinations, just going in by appointment type, by provider, and by practice, and looking out to find the third next available appointment and noting that time. Another benchmark that's out there is number of visits. My personal opinion on this one, it's difficult to compare when appointment durations vary within and among providers. If all appointments were the same duration for all providers, then this could be a readily usable benchmark. You might find this in open access scheduling or schedules which have all appointments are equivalent duration regardless of reason for seeking care. So for instance, if there are only 15-minute appointments on the template and everybody's scheduled into that, or only 20-minute appointments on a scheduling template and everybody is scheduled into those regardless of their chief complaint or reason for seeking care, then number of visits can become very benchmarkable. But if you have 5, 10, 15, 30, 60-minute appointment types, the complexity varies, the number of appointments per day vary, and so somebody who is seeing 10-minute minor acutes all day will have a huge number of visits and can be impacting same-day access, but may not be something that's comparable across individuals or specialties and comparable against external benchmarks. Panel size has gotten a lot of attention over time and is getting renewed attention, but there are a number of difficulties with panel size. Panel size can be very useful in primary care practices that are in full risk or a capitated care model, a reimbursement model kind of scenario, because you accept risk for the impaneled patient population. So you're in a mutually contracted relationship, you have a captive population, you are tasked with taking care of those patients in the best, most effective and most efficient way possible. And so therefore, however you care for them, becomes very important. It's difficult to determine panel size in fee-for-service markets, as there's no guarantee that the patient will return or have an ongoing mutual relationship. Some measures out there and metrics out there look at, if all your established active patients with at least one encounter in the past 3 years, so the definition of an established patient, but that's overly inclusive. Some of those patients may be deceased. Some of those patients may have moved from the area. Some of those patients may never intend to come back to you for care. A little bit more restricted is looking at established active patients with at least 1 or even 2 encounters per year, because those individuals are likely to have a mutual relationship. Panel size can be impacted by patient complexity, practice support, and care delivery model. And so in looking at really accurate determinations of panel size, determining risk stratifications is highly recommended. That way you allow patient weighting and some equivalency determinations across providers. One thing to note is patient panel size, does not directly measure actual access to care, right? It just says you've committed to care for this number of patients, but it doesn't measure how well you do that or how well patients can get in to see you. So you can have a panel size of 5,000, but if patients can't get in to see you, it's actually conflicting ends in this manner. Again, a standard size does not exist. The average size varies from 1,400 to 2,000. There is a simple calculation, but access itself is impacted by template management, provider practice patterns, and all the things we mentioned before. If you are in a capitated environment and want to look into all the things with panel size, these are various references that can do it. But again, measuring panel size does not necessarily measure access that the patients on the panel have to care with the provider. Ideally, if the panel is appropriately sized and based on complexity, access can be handled better, but it's not directly measured. A final recommended metric that's out there for measuring patient access is actually a proxy, and it's looking at productivity measured in RVUs per provider. In my opinion, it's a relatively ineffective measure of actual access. Accuracy can be impacted by coding accuracy and other aspects. This would be better used to determine provider capacity to expand volume or enhance access. So, for instance, as we look at some of the factors that we'll talk about here in just a minute, if we're looking at a medical staff development plan and we're looking at the supply of various providers within the market, looking at their productivity and how it benchmarks against others can give an idea if there's capacity to expand volume or enhance access, but it doesn't really measure access. We will talk about one caveat with that. If you're a 90th percentile producing provider, it's going to be very difficult for you to expand volume or enhance access because you really are at your limits for most humans. So it can play a factor, but it's usually not a primary factor in determining access, but a secondary factor that looks at, the ability to expand volume or enhance access. So we mentioned there, now that you've measured and come to some understanding of where you think your patient access lies, and you want to look at ways to improve access, what elements, where do we drill down, and what factors do we look at to ascertain whether there is an ability or how we can increase access to care? And so we'll look at about, 8 or 9 different factors that can directly affect patient access and talk about each of these in turn. So the supply of direct care providers, how these direct care providers are utilized, the supply and capabilities of support staff, both are very interchangeable or necessary rather, and how the support staff are utilized in the care delivery model. What is the practice's culture? Are there physical space restrictions that restrict access? How does provider compensation plans factor into the patient access equation? And do EHR capabilities have a role as well? So let's start with supply. And this is the number and mix of physicians and APPs within the employed network or within the market. And it's a foundational element of defining access because you cannot access providers that do not exist. Similarly, it cannot increase access for providers who are already, quote, maxed out. So we alluded to this just a minute ago in saying if you have a provider that's producing above the 90th percentile, that individual is unlikely able to sustain any increase in access over the long term, and recruitment really becomes a better option to increase supply. However, if you have providers that are producing at the 10th percentile, the number of providers may not be the issue. It may be some of these other factors we'll talk about in a minute. The tools to work on and drill down into the supply of direct care providers, we feel is founded in the medical staff development plan. This determines the recommended supply by specialty for the population served and adjusted for the incidence and prevalence of certain disease conditions. But just determining the medical staff development plan or a lower version of that, which is the physician needs analysis or provider needs analysis, which just looks at numbers, is having a strategy to achieve the recommendations. You really need to have to apply an internal interpretation of the suggested needs in a needs analysis. and define the priorities for recruitment, including strategic locations or strategic increases to target service lines that you want to target. This is really important because the medical staff development plan may not show a need, but you want to strategically enhance a service line, and so need to target that to increase your ability to provide that level of service. So supply, very important, and a mechanism to do it through the medical staff development plan and the physician strategy or provider strategy to fulfill the medical staff development plan recommendations. Even with an adequate supply, and not underestimating the foundational requirement of supply and knowing if supply is adequate, the numbers of providers that you have to be effectively utilized and supported. We alluded to that a minute ago in talking about 10th percentile providers and looking at why they're at the 10th percentile. Are we utilizing them as well as we can? Are we supporting them as well as we can? And one of the foundational elements of utilization is looking at template management. This involves a critical review of the types, the duration, and numbers of appointments per day, and will vary based on specialty and circumstances. So, for instance, the numbers of appointments per day can be impacted by seasonal demand. For instance, perhaps more same-day acute access in the winter when illness is usually has a higher incidence and prevalence. This can vary based on provider experience level, having longer duration appointments and less appointments today coming right out of training, but then ramping up over that 3 years of maturation. And we already talked before about patient complexity and recognizing that. And if there is a risk stratification process in place, then the higher risk patients might merit longer appointment durations that are utilized according to their risk stratification complexity. And similarly, younger, healthier individuals or just healthier individuals with a lower risk stratification score might be well taken care of in appointment types of lesser duration. The biggest thing with template management is there should not be arbitrary variation within specialties. There are benchmarks available by appointment type and specialty. For instance, a primary care benchmark for new patients is 30 minutes. And for those of us who can recall practicing 40 years ago, a traditional new at that time with a paper record and everything done on site by the provider was usually a 60-minute encounter. But now we have the ability to complete patient history questionnaires either online or through support staff and decrease the amount of time that the provider takes to ascertain that patient care, that patient information, and just review and utilize that patient information. A similar event with preventive care visits. No longer the need for 60-minute preventive care visits when we have the ability to streamline the actual encounter. This does not mean cheating patients and the time spent. What this means is more effectively utilizing provider time and more effectively using support staff and other tools to allow the provider to be just as effective, but more efficient. If we look at other of the utilization tools, the scheduling process is another area. What are the rules for patient engagement and appointment utilization, and who can adjust them? Can I cancel an appointment today just because? Or are there rules for how we engage patients and utilize the schedule? This is where centralized appointment scheduling can be helpful, but many organizations rely on this as the buy-all and end-all, and perhaps it should be an 80-20 rule or 90-10 rule, where the centralized scheduling is used for routine requests and filling appointments for routine requests, and the clinical input is sought when requests cannot be met by the published schedule. So, for instance, if the patient expresses a need to be seen tomorrow, and there isn't an open appointment tomorrow, having the clinical support staff and or provider involved to figure out how to accommodate that request, this should not rest with centralized scheduling, but should rest with the office environment. That approach can also be an impetus to look at our template management and look at our utilization patterns to make sure that we've designed them in a way that accommodates most usual requests for care. And so individual intervention becomes an exception. No-show management is a huge issue with schedule utilization. Patients failing to keep scheduled appointments affect appointment availability and operational efficiency. There are no two ways about it. The risk for no-show by many studies increases as the interval between the scheduling of the appointment and the day of the appointment lengthens. This is one of the primary tenets behind open access scheduling, taking care of business today. So a patient calls today for routine care, and they're offered care today so that we minimize that no-show element. There are many mechanisms through which to manage no-shows, appointment rates, appointment reminder processes. There are multiple types of those, so we won't go into those now, but no-show management is also a huge part of our utilization of direct care providers. And then again, we talked about open access scheduling. So we have supply and utilization of direct care providers. Just about all the factors that we're going to talk about from this point on are how can we support providers to maximize their efficiency and effectiveness, not necessarily in that order. We'll talk about effectiveness and then efficiencies. And that really is the rest of the drill down. So when we talk about the first key personalized element is the supply and capabilities of support staff. The numbers, types, skill sets, and turnover, a big deal about turnover and having consistent support staff presence are just critical factors in looking at the practice's ability to maximize patient access. And when we're talking support staff, it's administrative support staff like office management and front desk personnel, as well as the clinical support staff that's usually lumped into nursing and care managers. There are various metrics looking at quote, adequate support staff. There's staff per physician, both administrative and clinical, staff per provider, staff per 10,000 RVUs, and then on the care manager side per X number of beneficiaries. And the X is there because the number of beneficiaries per care manager will vary based on what the role the care manager has. So is it chronic care management? Is it transitional care management? Is it any of the other facets of care managers? That number will vary based on role. So one of the fallacies that many rest their hats on is just looking at the metrics and saying, see, our staffing is adequate. Well, the quantity of staff may be adequate, but the quality and mix may not be. And the quality and mix are significant attributes for efficiency and effectiveness, and both of those impact access and cost. All these individuals must be adequately trained to effectively execute the roles and responsibilities of the position, and they need to be consistently present. The supply also will vary by care delivery model, and we'll talk about that here just for a second. If we look at where we're going in the ultimate care delivery model for the future, it requires top of license utilization of all of our support staff. And that's not just top of license, but top of capabilities. And training the support staff up to a higher level of capability so that they are able to very directly impact care delivery effectiveness and efficiency. Most of the future envisioned care delivery models are team-based care, which tend to involve pre-visit reviews, expanded rooming processes of clinical support staff, huddles at half-day or before patient encounter, standing orders to allow staff to do things like preventive service orders, and then team documentation to decrease the amount of documentation that's rested on the providers. Another aspect of this is RNs or LPNs or even really good MAs performing Medicare annual wellness visits. Even for the initial, the IPPE encounter or the Welcome to Medicare encounter, which requires the interaction with a direct care provider, this RN, LPN individual can actually do the lion's share of that lengthy interaction and streamline the provider's utilization in that encounter. If you look at the annual wellness visits beyond that initial visit, the initial second year and subsequent, those can be performed solely by a licensed professional under the supervision, indirect supervision of a direct care provider. Utilizing this in this fashion frees direct care providers for other types of patient care, but still maintains comprehensive care and still maintains patient care revenue within the practice. Another aspect of the care delivery model is having multiple points of access. Have we embraced virtual visits to augment our on-site visits? Did we maximize the patient portal and asynchronous communications to provide care? And again, looking at the scheduling process to make sure that we can accommodate multiple interactions and different points of care. So there's a lot that can be done with the care delivery model and support staff to really enhance access to patient care with the same number of providers, and not needing to increase the number of providers, but more effectively and more efficiently utilize the providers, yet still provide very effective, very safe, and very comprehensive care to patients. The practice culture needs to allow this to happen. And so as we look at the practice culture, and especially if we look at the physicians and APPs, have we incorporated and maximized the utilization of APPs? Do we look at our practice patterns? There can be significant potential for independent practice variation in preferences and capabilities that may not be warranted. Warranted variation should be accommodated. Unwarranted variation should be sought and eliminated. It's almost like a lean mentality of reviewing care. Patient sharing, moving from a mine mentality to an ours mentality. Looking out for what's best for the patient and not worrying about how you may perceive that can impact how the patient feels about you in particular. We should all strive for continuity of care, for sure, no question about it, and strive for that at all times. However, there may be times where we just need to share patients and for their best interest. Having a customer service focus, this gets back to patient sharing and a patient-centric focus as we look at our hours of operations, multiple points of access for care, and those types of things. But staff and direct care providers, physicians, and APPs really need to have that customer service focus. We need to be patient-centric in that thought process, and we need to be able to keep the patient at the center of our decision-making, and patients' access to care needs to be primary. There are tools to measure this and look at practice culture. Many of the CGCAP responses deal with that, both at the direct care provider level, but also on the support staff level, and how we were treated and how we perceived our care. So there are ways to look at the culture, but most importantly is getting in there and looking at the culture, both in a self-introspective way by the individuals involved, but also by the system. Physical space cannot be underestimated. It must be adequate to support the care delivery model, and the notable components would include exam rooms per provider, whether it's per patient day or half day. And if we look at the team-based care delivery model, that generally requires 3 exam rooms per provider and 3 MAs per provider, 1 for each exam room. Consider the impact of others who need to interact with patients, like the RN or LPN doing annual wellness visits, and other nurse-driven care like throat cultures, blood pressure checks, those types of things, and the presence of care managers who need specific space to do their function as well. Coming more and more to the fore are conference room settings where you can do group visits, group diabetic visits, group prenatal visits, those types of things, and patient education endeavors, looking across the continuum to better engage patients in their care, and better leading to better outcomes. There are some tools looking at exam rooms per provider or square footage per provider against benchmarks, but these may not be current for our new care delivery models of team-based care and requiring more space. But if you have 3 providers and 3 exam rooms, it's going to be very difficult to increase access or have reasonable access because you just can't turn patients over. No matter how many staff you have or how many providers you have, if they don't have the space to be effective and efficient, the number won't matter. The type of provider compensation plan can have a significant impact on patient access. And you might not think about it in the beginning, but what we incentivize, or what the compensation plan incentivizes, can really influence the receptiveness for increasing patient access. So if we look at a revenue minus expense model, it does promote maximizing access, but it does not promote patient sharing. It promotes lean staffing, which may thwart team-based care delivery models and care management models. So while it may enhance access on one aspect or element of patient access, it may thwart others. Straight productivity promotes maximizing access, but not patient sharing, team-based care, those kinds of things, unless it's how that impacts my ability to see more patients to get paid more. Straight salary, no matter how you cut it, it does not promote maximizing access. Straight salary promotes, I will do what is minimally required by the contract, and I'll do it well, but don't ask me to do too much because I only get paid to do the minimum. Base plus incentives can work a number of ways. If they're solely individual productivity incentives, it again can promote access but not sharing, just as the straight productivity model does. The ability to promote access and patient sharing, though, can come with the introduction of group productivity incentives or team-based incentives, and where we want to incentivize the whole working better and the whole contributing to patient access and patient care. When we look at the EMR, there are a couple of things to think about, and it impacts both the clinical and the practice management components of the EMR or EHR. The platform may have capabilities and limitations that must be considered in our care delivery process, one aspect of which we talked about multi-point access. And if the patient portal is non-existent or not very capable, it can limit our ability to enhance different types of access rather than in-office access. Inefficiencies in the record capabilities also can make individuals less receptive to seeing more patients and increasing access because they spend so much time working through the inefficiencies of the EMR. Staff training and proficiency within the EMR is huge. Again, the more facile the staff are with it, the better and more smoothly operations run, and everyone is then on board with being able to increase access because it's not any additional patient is not additional pain with interacting with the platform. This usually requires adequate IT support, which often does not exist in the ambulatory environment. And finally, not to be underestimated is internet or web connectivity and speed, especially in your off-campus offices, but even on campus. There are parts of the on-campus office structure that just aren't well connected. And the further you go away from campus and the more remote your office locations are, especially in rural environments, the web connectivity and web internet speeds can be woefully inadequate. And you want to make sure that you are maximizing the ability of the staff. If you literally have to wait a minute between each screen, it's just very difficult to be both effective and efficient, and very difficult to want to increase access because just every minute of care delivery is such a pain. Tackling these can occur through a provider leadership council, clinical informatics committee, or a user group if you don't have those capabilities. And there's a huge amount of information about the ability of using scribes, whether they're on-site in-person scribes or virtual scribes, which is a burgeoning business now. These can generally be paid for with one to new or 2 to 3 additional established patients per day covers the expense, but the impact on smoothing interactions and having staff more receptive to seeing more patients and enhancing access cannot be understated. So these are a number of the factors to drill down into and see how they positively or negatively affect patient access. But as we approach this topic with our staff, whether it's provider staff or support staff, we need to be cautious in our approach. So the common tendency is to talk about revenue, financial sustainability, and those aspects of increasing access. I would recommend that as we talk about patient access issues, we have to look at maximizing access for the benefit of the patients, both our current patients and our future patients, our established patients and our new patients, and the frustrations that the staff deal with in trying to work around systems that do not promote timely, convenient access to care. Sometimes working around the system consumes so much time and energy, it just consumes our support provider and support staff workday. And so, maximizing access for the benefit of the patients, but also maximizing the benefit for our providers and staff by minimizing the complexity of the scheduling process and the need to develop workarounds and dedicate time to fighting fires as opposed to caring for patients. We should have equitable expectations of providers across any network. So as you look at your provider network, your medical provider network, and you're looking at access across specialties or across offices or across providers, there should be an expectation of equitable expectations. We should have the same expectations for our providers, and we should try to approach it from a fairness perspective. It's unfair to have higher expectations of one than another and not holding the other accountable for their lesser expectations. Consider the potential impact on provider compensation as an incentive, and consider the impact on provider compensation plans to align the incentives within the compensation plan with our desire to incentivize increasing and maximizing patient access. The bottom line is, if we do take care of the patients, the revenue will follow. If we can do all these things and maximize access for patients and minimize the hassle for our providers and staff, we will be sustainable. We will attract and retain patients, and increasing revenues will follow, though this should not be the focus in going out and talking about increasing access to care. We shouldn't ignore the financial impact. We should not ignore the need to be financially sustainable over time, but this should not be the primary point of emphasis with these initiatives. It should be on the patient, it should be on the providers and staff, it should be on being fair and equitable across providers and staff, and aligning incentives so that we're all working toward maximizing patient access to the care that is perceived to be needed. So with that, that concludes our educational session for today. We thank you for participating in this session, and we hope that you found the presentation to be of value. Thank you very much, and have a great day.